I didn't even want to go to sleep. The nightmares were so bad.
That image kept coming back to me. I didn't want to remember it, but there it was.
I felt like I was right back there in the middle of that horrible day. The smells, the sounds, it was so real.
I tried to go grocery shopping, but I couldn't be around all those people without seeing the exit.
These are the voices of post-traumatic stress disorder, or PTSD. Almost everyone lives through something traumatic at some point in life. Most people have a lot of distress right after a trauma happens, but begin to feel better over time. For other people, the distress sticks around, and they begin to have symptoms that really affect their lives. For these people, it is almost as if the trauma is still happening, all the time, everywhere, long after it has passed. I know, one of these voices is mine. What do we mean by trauma? When we're talking about PTSD, a trauma is a horrible experience where you might have felt afraid for your life, or you were injured physically or sexually, or were afraid you would be. You can also witness a trauma or hear about it happening to someone you care about. First responders, medical people, and clergy can also experience trauma by hearing others talk about it. For me, it was combat. I saw some really horrible things, and I often thought I might be killed. PTSD develops in some people and not in others. Everyone experiences horrible things differently, and everyone reacts differently, sometimes for years or decades after the event. If you experience post-traumatic stress, it does not mean you're weak or that you can't handle hard things. It may make you feel weak or unsafe, but a lot of strong, brave people are affected by PTSD. And it is treatable. Your provider might think about a diagnosis of PTSD if you've lived through something awful, and if you have some specific symptoms for more than 1 month. Intrusion or re-experiencing symptoms. This is the memory of the trauma coming back. It can show up as unwanted memories, nightmares, flashbacks, or feeling horrible after being reminded of it. For me, I kept seeing this one image of a Marine who had just died, and that memory haunted me. Avoidance symptoms. People go out of their way to avoid anything that reminds them of what happened. Some people avoid things like thinking about the trauma. Others avoid people or places or anything else that makes them remember. I couldn't deal with crowded restaurants or movie theaters. I felt unsafe there, so I stayed away, and it affected my family life a lot. Negative changes in thoughts or feelings. This can seem like depression or thinking I'm not safe. I felt sad and didn't feel interested in the activities I used to love. I isolated myself. Other people feel self-blame or might not remember the event well. Some people feel numb or disconnected. Changes in reactivity or arousal. This means your body reacts to things much more than it used to. You feel irritable. You might take risks or act self-destructive. A lot of times you have trouble concentrating and you're always on guard. I was jumpy and loud noises really startled me for a while. I also couldn't sleep for months after coming home and had to take medication. PTSD makes people feel horrible, but I found a way to ask for help. I learned there are several treatments proven to work for combat veterans like me, as well as for survivors of all other types of trauma. These therapies have names like CPT, PE, and EMDR, and they help people get through the trauma by learning to change how they think and feel about it. I was able to get back to living. PTSD is challenging, but there is hope. Talk to your doctor and get some help because treatment works. People can learn to live again. I know. I did.
Hello, everyone. I'm Dr. Foojan Zein from United States, California, United States, originally from Iran. And I am the host today for the weekly sessions that we have with the International Women in Psychology, which originated with a beautiful lady in India. And now we have, I think, over 250 countries, psychologists, women psychologists from all around the world with us. And I think it's an asset. I think it's beautiful to be able to, for all of us to be together and learn from each other. Today, we're going to be talking about PTSD, post-traumatic stress disorder. And we have wonderful presenters who each one of the presenters will be taking one part of the concept of post-traumatic stress disorder and explaining it. And I hope that you all enjoy it as much as I'm sure we will, learning from each other. So the first topic would be, what is PTSD and its various types? This would be presented by Amira Hamad Al-Rashid. Amira, I am unmuting you or asking you to unmute yourself. If you could please do that. Wonderful. We're not going to have Amira's beautiful face, but we will definitely hear her and enjoy her conversations. Go ahead, Amira.
Hello, my name is Amira Al-Rashid. I'm from Saudi Arabia. I'm a clinical psychologist. And today I will be presenting the definition of PTSD and the types of it. So post-traumatic stress disorder is a psychiatric disorder that may occur in people who experience a traumatic event, such as a natural disaster or a serious accident, a rape, or any sexual violence or serious injuries. They experience disturbing thoughts, feelings, and they may relieve the event by flashbacks or nightmares. The types of PTSD are 5 common types. Normal stress response. The normal stress response occurs when a healthy adult who have been exposed to a single distress traumatic event in his adulthood. They can experience intense bad memories or emotional numbness. Such individuals usually achieve complete recovery within few weeks, often by a group of debriefing experience regarding their normal stress response. The second type is acute stress disorder. It's characterized by panic reactions, mental confusion, dissociation, or severe insomnia. This type of PTSD is common by they're not able to manage their basic life care. So like they are not able to care about their hygiene or work or even relationship activities. The third type is uncomplicated PTSD. It involves persistent or re-experiencing of the traumatic event, avoiding stimuli associated with the event, such as lights or the situation that reminds them of it. Symptoms could be increased if they were experiencing the same situation. So, for example, if war combat people would come back after war, if they saw lights, the memories itself would come back to them. So the third type is comorbid PTSD, meaning that it could comorbid with another disorder such as depression, anxiety. The final type is complex PTSD. It is found among individuals who have been exposed to prolonged traumatic circumstances, especially during childhood, for example, childhood sexual abuse or verbal abuse or physical. These individuals often are diagnosed with borderline or antisocial personalities, or any other mental illnesses. And these are the 5 types of PTSD. Do you have any questions?
Can we let everybody speak, and then we would ask all the questions? Would that be okay with you?
Sure.
Beautiful. Thank you so much for telling us what it is and the various types. I would like to ask Liuba Ulaa to speak from the concept of what are the symptoms of post-traumatic stress disorder. Can you please unmute yourself?
Okay. Well, the symptoms by post-traumatic stress disorder, well, in most cases, the symptoms develop during the first month after the traumatic event. In minority cases, there may be delay of months or even years before the symptoms start to appear. Some people with post-stress, I'm sorry. Well, some people with post-traumatic stress disorder experience a long period when their symptoms are less noticeable, followed by periods where they get worse, and other people have a constant and severe symptoms. For example, we have one type, re-experience or memories, for example. Re-experience is the most typical symptom. This is when a person involuntarily, vividly relives the traumatic event. For example, it could be by flashback, nightmares, repetitive and distressing image sensations, physical sensations such as a pain, swearing, feeling sick, or trembling. Some people have a constant negative thoughts. They experience repeatedly asking themselves questions that prevent them coming to terms with the event. Another type is avoidance and emotional numbing, trying to avoid being reminded of the traumatic event is another key to symptom of post-traumatic stress disorder. This is usually means avoiding certain people or places that remind you of the trauma, and avoiding talking to anyone about your experience. For example, many people with this disorder try to push memories of the event of their mind, for example, often distracting themselves with work or hobbies. Some people attempt to deal with their feelings by trying to not feel an all is an emotional numbing. For example, this can be lead to the person becoming too isolated with a drum. They may also give pursuing activities and they using to enjoy. Another type, we have hyperarousal, behavior change and mood swings. For example, someone with post-stress disorder could be very anxious and could find difficult to relax. For example, they may be constantly aware of traits of easily distracted. This state of mind, aunque no hiperarousal, for example, it could have irritability, angry, sleepy problems, insomnia, and difficult to concentrating. Other problems, it could be other mental health problems such as depression, anxiety, phobias, self-harming or destructive behaviors such as drug misuse or alcohol misuse. Another atypical symptoms such as headache, chest pains, stomach aches, and others, for example. For example, I would like to focus on the two child with stress disorder, no, it's post-traumatic stress disorder, because they can have similar symptoms with adults, such as having trouble to sleeping, having nightmares. Children may also interest in activity, lose the interest in the activities. They may have physical symptoms such as headache, stomach ache. Another common symptoms is difficult behavior, avoiding things related to a traumatic event. For example, reenacting the traumatic event again. Well, the most common is problems with their behavior, and others. Well, that's it.
Thank you so much. I would like to ask Celeste Jacobs Richards from Africa, Swaziland, Africa, to share with us what happens if PTSD is untreated on time. If you could please unmute yourself. Thank you.
Thank you very much. Hi, everybody. I'm Celeste Jacobs Richards from Eswatini, and I'm a clinical psychologist in private practice for 13 years now as a psychologist, as well as doing work in the wellness field in corporates. So I'm going to look at and present what happens if we don't treat PTSD simultaneously. I think we need to recognize that generally PTSD is a progressive illness, and it's probably not going to go away on its own without any treatment. We've just heard some of the symptoms for PTSD, and so when I explain the things that could go wrong if left untreated, you'd be able to link it back to the symptoms to make sense of it. The problems for the individual will probably be holistic, meaning it will be social, occupational, psychological, as well as physical if left untreated. So I've tried to break it down for the sake of ease and for it to be more articulate. We'll look at the psychological parts of what would happen if it's untreated. People can then end up with comorbid diagnosis, such as panic disorder, depression, substance abuse or substance dependence, and it can lead to fatal situations such as suicidal ideation, suicidal attempts, or successful suicide. And we can understand that based on the avoiding, the numbing, hyperarousal, as well as the behavior change and mood swings, which were spoken about in the symptoms. We can also then look at the occupational side of a person's life. If a person is not doing well and they're always anxious or they're irritable and they are numbing and avoiding dealing with stuff, you can see how this could affect them at work. So there could be loss of a job, loss of income, due to not being able to concentrate, not being able to perform because of memory problems, absenteeism because of feeling unwell. So we can see how one's occupation or academic path can be affected by untreated PTSD. Socially, based on the symptoms of anxiety and obviously somebody having mood swings and not feeling good in any situation or worried about having flashbacks, being hypervigilant or hyper-aroused, we could definitely see that impacting relationships, whether intimate family, friends, work colleagues, holistically, relationships would be affected. A person would probably want to isolate and be on their own if they're not feeling great. There may be a lot of fear because there's a lot of anxiety linked to PTSD. It can also lead to conflict in relationships based on perspective that obviously is going through a filter of anxiety. There's also the issue of sleep and appetite being impacted, which I think then obviously leads to the physical effects and the medical health effects of untreated PTSD. We all know that a lack of sleep and a lack of food is just obviously one of the most unhealthiest things and the basic coping skills for any form of mental illness. And so we can see how that would impact somebody's physical health. And then also if somebody's in a constant state of hyperarousal or hypervigilance or anxiety, that definitely will impact the endocrine system and probably the brain in the long term if it's not treated. So I've tried to summarize and touch on the different areas to show how overall an individual who does not have treatment for PTSD timelessly will have a decreased quality of life holistically in the different areas. I hope that's touched on the issues that could arise based from untreated PTSD, and also I hope that it's been able to link it so that you can see the link to the specific symptoms of PTSD and not necessarily just any diagnosis.
Thank you.
Thank you very much.
Thank you. I will ask Maimuna Sharif from Kenya to speak to us regarding what are the causes of PTSD. Maimuna, thank you for joining us, and I'm asking you to unmute yourself, please. Thank you. Go ahead, please.
Hello, everyone.
Hello.
I'm going to talk about the causes of PTSD. It's not that much, but I'll just touch it briefly. What causes PTSD? The situation varies from person to person. Traumatic situation can vary from, let's say, from a female to a male. There are many different harmful or life-threatening situations can happen, can cause someone to develop PTSD. Like, for example, if someone is involved in a car accident, that traumatic event will come back after some time. Okay, like a violent attack, or sexual harassment, rape, that kindly happens mostly, can cause PTSD, and in military combat, or seeing other people hurt or kill, after sometimes that feelings can come back to you. Or like a traumatic childbirth, either as a mother or a partner, witnessing the situation of that childbirth, the situation of giving birth. That situation is a very traumatic, even for the females. Extreme violence or war, that like military combat, that's what I said already. Surviving a terror attack. Maybe even learning that traumatic event have affected someone close to you sometimes can be a secondary traumatic to the other person, not immediately. Any event in which you fear for your life or for your family, your close ones, can cause someone traumatized. Like secondary trauma can be that it's not that severe, it should be mild, it's somewhere just that is what I've prepared. I haven't prepared that much, it's not that big, it's just.
Thank you so much. I have Alicia Somorcurcio from Peru assigned to speak regarding how PTSD is diagnosed. I don't see her name here, so if Alicia, you're here, please let us know if you're here. If not, then I will continue with the treatment. It seems like she's not here with us. So I think that to answer what Alicia was going to talk about with us is how is it diagnosed is basically looking at the symptoms that Iluvat already talked about. So you go like any other diagnosis that we do the assessments, we look at the symptoms, and if they have the symptoms, obviously they're diagnosed for that. So we've already gone through the symptomology. So if you allow me, I will go through the treatment for psychotherapy and even medication management that we have. So the common treatment for post-traumatic stress disorder in psychotherapy is cognitive behavioral therapy, which is very common and is mainstream. And within cognitive behavioral therapy, what we do is, since the person who has been through a trauma, they've definitely experienced powerlessness and stillness in that moment, and they have generalized it to many other areas of their life. What we do as cognitive behavioral therapists, we challenge the maximization and attempt to look at all of maybe the irrational beliefs that they have maybe created about themselves in other situations when they had to face death or when they had to face powerlessness, and find their strength and resilience in other areas of their life, and gear them toward that and shift their meaning that they've created, irrational thoughts, beliefs, and belief systems, negative ones that they've created for themselves, toward a positive belief system about themselves, and bring out their resilience. Another type, the second type, is prolonged exposure therapy, which it takes about 8 to 15 sessions of 90-minute sessions. Usually the therapist begins with teaching them anxiety reducing and minimization techniques, such as breathing and how to calm down their body. And then they will help the patient, client, to go toward the scenario, some of the visual perspectives of the trauma. And as their body elevates with heart rate and their anxiety shows up, they stop, they guide the client in order to calm their body down again, to create containment for their emotions, and to rise tolerance for those emotions, and they'll go back again to exposing them to the actual traumatic event. And this way they go through the whole event, creating power for them, and for them to feeling empowered, and they're no longer powerless, and knowing that they've survived it, and looking at the strengths that they have moving forward from the actual event. A very common and very much researched methodology is eye movement desensitization and reprocessing, which was founded by Francine Shapiro. It has become mainstream. I call it a magical technique. It happens with movement of the eyes back and forth in different angles, or with audio audio sounds from right to left ear, or actual touch of tapping for either the palm of the hand, or I actually do it with the knees of the clients, and do an alternate tapping. What EMDR was found was that when they changed the eye movement from right to left or up to down, it seems like there was a correlation that got created, interconnecting the right brain and left brain. And it helped a lot with the processing of the trauma, the visual, the cognitive, the emotional, and releasing from the body. I call it magical because I've used it with different types of traumas, whether we were accident, or I've worked with veterans who came from war, or worked with even what we call small traumas, which were childhood traumas. And it really does have an amazing effect, even with less than maybe 3 to 4 sessions of 90-minute sessions. The fourth one is stress inoculation therapy, where basically the person is not necessarily dealing with the traumatic event itself, but they go into a space alone, where they attempt to manage the stress that is happening in their body through exercise and anxiety reducing techniques for their physical aspect and meditation. And they build their resilience from that perspective, and only deal with the stress. There's also medication that helps for the neurotransmitters and serotonin boost. Sometimes what they offer is Prozac, Paxil, Zoloft, or Effexor, and other antidepressants. At times, if the person has gone to a place of psychosis, they also offer antipsychotic second generations, beta blockers, or benzodiazepines for anxiety. The newer kind of more biological treatments are transcranial magnetic stimulation, which targets an area of the brain that are underactive in people with depression from PTSD, where they will sit the patient under an actual equipment, where that equipment does brain mapping and finds the area of the brain that is not active, and they start stimulating it with electromagnetic pulses. And so it's different than ECT. This is not electroconvulsive therapy. This is electromagnetic therapy. And with all of the research that has been done, it appears that it alleviates the depression by shifting a little bit of the brain stimulation and the depression and anxiety that has gone created from post-traumatic stress disorder. As far as other types of medication and treatments that are a little bit new is ketamine, which is a medication mainly was used for anesthesia. However, it's been regulated by FDA that can be used as esketamine, which is a lower dose of IV treatment under the supervision of a doctor that needs to be actually taken with the antidepressant. It seems like supposedly it boosts the serotonin of the brain in a shocking way, that it would kind of like restore the body and the brain, and it gives it signal to come back and produce its own serotonin. It appears that with people with PTSD, their brain gets shocked and stops producing serotonin, and they have a tremendous amount of depression afterward. And although they might be complete with the actual scenario of the event and the trauma, but their brain has gotten shocked into the low doses. So that's why apparently ketamine has been effective in that. And another way that they are using the medication is also MDMA assisted psychotherapy, which MDMA is pretty much speed, methylene dioxymethamphetamine, that is also used only with the discretion of working with the therapist and in specific doses. And there are centers that are actually working with this, with MDMA, which they do individual psychotherapy, group psychotherapy while they're under the dose of MDMA. Usually it stays about 3 to 4 days after the treatment in the body. Again, the purpose of that or the logic of that is that it boosts the serotonin in the body or in the brain of the person who has been completely depressed. So far, those are the treatments that are consistently being used by everyone. I'm going to open the conversation for questions, or if anyone else in the group has other suggestions, or with their experience, they've come up with something that they want to share with us with their clinical experience with their patients or clients. In order for us not to have a lot of noise, if you know how to raise your the blue hand in Zoom, I would really appreciate you to let us know who would like to share. And if I can see you, you can go like that, you can wave your, and let me see who it is that you would like to share or have more conversation, or if you have questions from each other that we could have a conversation. Who would like to share or has a question? And I can unmute all if you don't know how to raise your hand in that way. I can ask all of you to unmute yourself so you could ask questions. Any other questions? Any other experiences? Celeste?
I think yes, thanks. The one thing that I wanted to share that I thought was quite significant while we were all presenting as the subjective experience of trauma, for us as healthcare professionals to recognize and acknowledge that what's traumatic for me may not be traumatic for you, and that it's a very subjective experience of how you internalize, perceive, and process the event that has occurred. I think one of the things I've noticed with some of the clients I've worked with when they speak about others or about things that they've been exposed to is that there's a lot of expectation or what is the word I'm looking for, or assumption that if this has happened, then this will be trauma. And I think it's very important for us to recognize that it's a very subjective experience. Not everybody who breaks their leg experiences it as a trauma, but there may be somebody who breaks their leg and it is traumatic for them, and it's for the recognition of that subjective experience of the individual. So I just thought that was something that would be important to highlight while talking about PTSD, that not every incident or event that you may perceive yourself as traumatic would be traumatic for somebody else, and that if somebody else perceives something as traumatic, we respect that as their experience and their interpretation. Thank you.
Absolutely, I totally agree with you. I've worked with a lot of people with sexual abuse as a child or physical abuse, and you're absolutely right that they've had very different experience and type of the trauma they've had. And sometimes they are also traumatized, but their symptoms of trauma does not appear the same, like acute way that maybe others are. I also think that there's a difference between whether that the trauma is experienced in a life-threatening matter, such as, you know, being in the war or being robbed at gunpoint or raped and raped in gunpoint, like knowing that you might die, or auto accident, than traumas that, for example, somebody was sexually abused by a member of a family for many, many years, or physically abused by their parents, and the concept of death wasn't there. I think that they're both traumatized. It's just that they're different. It affects a person different when they feel powerless or they feel like, I'm going to die. I'm powerless against death. And trauma can show itself in many different layers. I've worked with childhood sexual traumas where their trauma showed up in different phases of their life and appear that they were functional. And then, for example, when they became a teenager, or the first time that some parts of the traumatic experiences showed up in their dreams, or in the way that they were avoiding, or in the way that they were creating some false generalized belief for people. And then it came up after again when they wanted to go into in a romantic relationship, and then it came out again when they wanted to get married, and it certainly came when they wanted to have a child and their child was exactly the same age that they had the trauma. So you could see the same trauma showing up in different stages of their life in completely a different way. So thank you for sharing that. Anyone else who wants to share or has a question?
I have a question.
Yes.
Well, when someone has post-traumatic stress disorder, could have visual hallucinations. It could be always, or it depends on the situation.
My understanding is that people at times do have visual hallucinations. I think that some people who could become very, very stressed at a time, they could have it could be flashbacks and not necessarily visual hallucinations, but some people who their ego strength was not as strong, that they did go through a psychotic episode after their post-traumatic stress disorder, they could also have the visual hallucination. So the flashback would be internal, that they would constantly see images internally, which is part of the symptoms that you were also explaining. But the visual hallucination would be when they actually see the visions outside of themselves, and not necessarily the visions of the accident or the trauma itself, but their fears show up as visual images outside of them. By then, I think definitely the chemistry of their brain has shifted into a position that they've gone beyond and gone to psychosis, and we definitely need to have medication management at that time. For all PTSD, you don't necessarily need medication management, but if somebody has gone to the place of having the hallucinations, then my suggestion is really to have combination of medical management with psychotherapy. Anyone else who would like to share about PTSD or has questions? Dr. Jefferson, nice to see you again. I'm asking you to unmute. Would you like to share a little bit about PTSD? Each one of us have gone through a conversation. And also welcome. So whomever would like to speak, please let us know. Raise your blue hand or come up so we could you could share with us, or if you have any questions about PTSD.
So hi to everybody. I'm currently mobile, and hopefully I can have a really good signal. So PTSD is a very serious diagnosis. A lot of people right now during the global pandemic are struggling with symptoms of PTSD due to the fact that they're struggling with exposure to anxiety, hypersensitivity, and reactivity. And there are so many other things right now globally going on with, reactivity to violence and destruction everywhere, and, hypersensitivity to social injustices and things like that. We have a lot of things going on right now. Xenophobia. We have a lot of things that are affecting people nationally, in America and other countries as well. I think that a lot of people are now finally seeing that mental health and emotional health and behavioral health matters are larger issues in our community and impacting society on a larger scale than previously people had believed. And I feel like people who are suffering from like a history of sexual trauma are now removing the stigma that was previously associated with it. And so we're seeing, as clinicians, more people come in and start to be treated for PTSD. We're seeing EMDR take a more prominent stance and be introduced to more clinicians. More clinicians are starting to using it because it's more of a short-term treatment for people struggling with PTSD. It's one of the only treatment modalities that has been proven to be short-term and effective in resolving the symptomology of people who struggle with it every day, and to kind of relieve some of the relived experiences and things like that for people who are struggling with PTSD. But yeah, that's what I wanted to add to it. I think that it's one of the diagnoses that I feel sometimes people feel like it can't be cured, right? Because we look at all of the symptoms and we're looking at, okay, people are having recurrent dreams, and they're very, very sensitive, and they're easily agitated sometimes and things like that. But when they've had that moment, that aha moment, and they see what's triggering, those relived experiences, and they can finally see, okay, this is what's happening. This is the precipitating event or the precipitating factor for me when I'm having those moments where I'm right back in that moment again, or I'm easily agitated, or I'm easily moved by this, or now that I'm having this anger outburst, this is what's triggering this, right? And they're able to move these things to the side and present with their best versions of themselves, because they're able to be more aware and be more in the moment. What I noticed is that when people become more aware they're able to control of themselves that present as more impulsive. And so it looks more like they're actually cured, right? So I'm noticing now that when we have treatment modalities that are presenting some things like EMDR, DBT, other TF, CBT modalities, things working, some modalities, I'm noticing that people are actually experiencing an alleviation of their symptoms.
Thank you so much. Thank you for being with us. Anne, you have your hand up. I'm asking you to unmute yourself.
Okay. Hi, everyone. Sorry I joined in late, but I have a question that I get most of the time from my clients who are going through PTSD, and most of them have been put on medication. So their answer constantly as we are going through therapy combining with the medication is, am I going to be on this medication for the rest of my life? So to some instances, as we continue with therapy, they feel like they are progressing, and I've found 1 or 2 clients who decided to leave the medication on their own without consulting their doctor. And after some time, they come back when they have, it's like they are having a relapse, or they are now not in a much better place than they were before. So my question is, do the ones going through the PTSD have to use their medication for the rest of their lives, or it depends with the diagnosis of how far that person is at? Thank you.
Thank you so much. I'll say what my experience is, and hopefully other people will pitch in. I don't know if we have a psychiatrist at this point in our panel that could also respond to that, because I think that respond would be more appropriate for psychiatrists and medical group that does medical management to respond. My experience with my clients is that the only reason that they are on medication is either they're it's not about the PTSD itself, is about whether that post-traumatic stress disorder has created heightened amount of anxiety or depression or some sort of a psychosis and mood irregularity. So they do take the medication to bring one of them down. Either if it's heightened anxiety and panic attacks after that, maybe the medication is geared more toward minimizing anxiety. If it's, they have deep depression, then the medication is toward that. Or if they have hallucinations or mood irregularities, what they do is they give them mood stabilizer or antipsychotic. Depending on whether the symptoms stay throughout the years or through the medication management and psychotherapy, it appears that the medication has done its job and the whole system is back and rebooted itself, then obviously under the advice of only under the advice of their psychiatrist, they can dose it down and work with their body so that their body is at a place that it could produce the same thing that maybe the antidepressant or anti-anxiety or mood regulators were attempting to do. There are some people that I've noticed, especially veterans that I've worked with, or people who already had acute symptoms of depression or anxiety as a default position, but it was untreated. And then on top of that, there was a trauma added where their treatment might be a lifelong treatment because somehow their body and their neurotransmitters are not able to ignite by itself, and for their brain chemicals, it's not there to be able to be produced. And at times, if that's the case, again, under the care of a psychiatrist, they might have to have a long-term or a lifetime usage of a medication. Would anybody else like to jump in on this conversation? No. All right. Any other question? We have time for one more question or a comment. Barbara, please unmute yourself. Go ahead.
Yeah. Now, there is something I really love to appreciate in treating PTSD, that is EMDR. I've used CBT, I've used other therapies, but trust me, EMDR has performed miracles. I had a client who was at war, got serious issues in the family. He lost his wife at home. The wife died, and he was shot, and he got serious damages. They thought that he was dead. The family thought the soldiers he was with thought that this guy was dead, and at least he was in coma for 2 months. So returning back to Uganda, it was really bad. Everybody thought that this person is dead. He's returning back. His wife is gone, and they had one child, and this child is very young. It was really bad. Using EMDR, that was in my 4th session after the history taking. It was a miracle, trust me. This guy, he went back to the real scene. He went back to the real scene. He says that in his life, he could not ever remember what had happened to him. But after the processing, during the processing, he said that he returned to the scene. He saw exactly what happened. I can say it was really great. He said he was feeling like, life is coming back to normal. He's returning back to himself, although he was at the scene. So at the scene, yes, it was traumatizing. It was really bad, but you'd see he was more enlightened. You see somebody having a lot of energy and saying, yes, now after this scene, I am sure I can face life. I can face life. I have seen exactly what happened to me, because his challenge was, how comes I don't remember what happened to me exactly? So with EMDR, processing the brain, processing the past, and of course taking him to the present, and later on he says that now I can see my future. Of course, I've tried to summarize it, but I can say for me, I have tried using EMDR on PTSD cases. It has worked for me. The same applies to people who are addicted. I work with them. You'll find that when you dig through their past, many of them have got trauma. And when you go EMDR, when you go and start the stage of processing, trust me, the traumas will come out, and they'll tell you that I've never got this therapy, and from the time I tried out, I did this therapy with my counselor, things have changed. So that is one treatment I felt has worked for me. I wanted to share that. Thank you.
Thank you, Barbara. Thank you so much from Uganda. Our time is up. It's 10 o'clock. I know that Dr. Jefferson wants to share. So Dr. Jefferson, in 1 minute, could you please share with us what would you like to share?
Oh, I was basically saying it's basically the same thing. So EMDR is one of the treatment modalities that I was talking about. It's the one treatment modality that has been empirically supported to cure PTSD. Although studies have shown for years and years and years and years that we thought previously that PTSD could not be treated and cured for the longest. Since 96 or so, Francine Shapiro's EMDR treatment has been the only treatment that's been proven to be efficient in actually curing PTSD, because the way it works, it taps into the REM part of the brain to where we're accessing the temporal lobe. And that's where the part of the brain where the synapses are responsible for processing and storing information. And that's where your traumatization actually starts, right? So that's where you store the trauma in a certain way to where that's why you experience the trauma the way you do, basically, because you store it in like a picture mode, like a child, so it doesn't have a sense of time, place, and appropriation. So that's the reason that when you reprocess it during EMDR, it actually heals, because you no longer have that hypersensitivity. So it desensitizes the reactivity. And so that's what Barbara is kind of referring to.
Yes.
So yeah, EMDR is a very effective treatment modality to use in helping people alleviate symptoms of PTSD and access the trauma.
Thank you. Absolutely, we shared different types. EMDR has been the highest one. Exposure therapy is side by side with it, with all of the research that has been done. But in the areas that those two have not been able to handle, I'm seeing a lot more research that are coming up with MDMA, psychedelics, and ketamine that are coming when psychotherapy in different forms was not able to handle it. Now they're also adding the medication, not only antidepressant, but some other sort of biological shift with the psychotherapy, which is beyond our scope of practice. I just wanted to share that. Thank you so much. I learned a lot from you, and I hope that everyone who watches us learns a lot. I think it's a great honor to be with all of the women psychologists from around the world, and thank you for participating. And until every week we get to do this and learn from each other. Take good care of yourself. Until next week.